Friends, welcome to my workplace at Ranaghat, West Bengal, India. I usually like to do hard cataracts under peribulbar block. Most of the time the block is good, but in this case the peribulbar block was bad. And actually it was worse than a topical phaco because the eyeball was turned superotemporally and the eye was moving in all other directions except inferotemporally. So this is a very tough situation for me. The cataract is very hard, nuclear sclerosis is about grade 5 and the patient is moving her eyes a lot, not following any instruction, and the block has been very insufficient. So after making the incisions, I stain the capsule with trypan blue dye underneath an air bubble, inject a bit of adrenaline, then I wash the dye using a 23J Simcoe cannula. And now 2% hydroxypropyl methyl cellulose, that is 2% HPMC, is being used to fill up the anterior chamber. And now capsulorhexis. I had to use a forceps to fix the eye for rhexis. Use a Utrita forceps, raise the capsular tag, go anti-clockwise all around, and my aim is to do a large rhexis. Size of the rhexis is about 6 millimeter, 5.75 to 6 millimeter, and this has been a very satisfactory rhexis. But the use of forceps may cause subconjunctival hemorrhage. And here, as I try to rotate the nucleus, the patient experienced pain. So what I do is, I keep irrigating, keep the IOP normal, and then rotate the nucleus. The subconjunctival hemorrhage has started. Visco has been again injected in the anterior chamber, and now the tip of the phaco needle goes into the eye. The machine being used is Ocular Cataract 3. The exposed part of the tip is little more because the cataract is very hard. And now I'm going to employ my technique, which I call submarine chop. The tip is buried completely into the substance of the nucleus, goes through the substance of the nucleus like a submarine, and as it reaches near the opposite equator, the chopper is used and opposing forces makes a nice crack, and this is called multi-level chopping. Go to a deeper level and make a good crack. Rotate 180 degree. 2-3 scalps, go to a deeper plane, and then separate the two heminuclei completely. Now each heminucleus is again chopped into two large fragments. The tip of the phaco needle goes completely into the substance of the heminuclei, and the heminuclei are chopped into two fragments. See again, it goes into the substance of the nucleus, goes near the opposite equator, and then it is chopped like this. And now as I try to rotate, my plan was to hold the piece on the left side, but this piece came out of the bag. So I had no other option, I had to manage this one first. And it is done. Each piece is tilted and its sharp apex is made blunt first. In this way we can subdivide each large piece into smaller pieces and then emulsify. Ultrasonic energy is 80% in continuous mode. Flow rate is 45 ml per minute and vacuum is 450 millimeter of mercury. This is the apex, it is made blunt first. And then the large piece is carouseled in this case, and it is emulsified. Till now we are still in high vacuum of 450 millimeter of mercury. Now my plan is to chop this large fragment into two smaller pieces, and when I emulsify the last small piece, I will decrease the vacuum. So this large piece has been divided into two smaller pieces and still in 450 vacuum. And now for this small piece, I go to Phaco on, that is scalp mode, where the vacuum is only 80 millimeter of mercury, flow rate is 25, and ultrasonic energy is 70%. At this time, since the vacuum is very less, the posterior capsule will not come forward. But we have to keep the Phaco tip at the center and keep the antechamber formed all the time. And since the vacuum is less, it comes out slowly. Now these smaller bits of nucleus comes out through the side port. And now you can see the subconjunctival hemorrhage has increased so much. So whenever we use forceps, there is a risk of subconjunctival hemorrhage. That's why I usually like to use a cotton-tipped Johnson bud. Just support the eyeball and do most of these steps. But some patients are so uncooperative, some eyes move so frequently that you have to use fixation forceps in some occasions. So the cortex has been cleaned. This side port is very small. Go through the left side port, and this is the final portion of the cortex. It is removed. And now this is the implantation of a hydrophilic acrylic intraocular lens. The lens has gone into the capsular bag. Irrigation of the anterior chamber. Visco that was there in the lumen of the cartridge comes out just by irrigation. And this is a bit of moxifloxacin. Now the side ports are closed by hydrating corneal stroma on either side of these stab wounds. The eye moved constantly, although peribulbar block was given in this case. So sometimes we have to raise our skills, we have to go through rapid heartbeats, increase our skills and overcome challenging situations. Wish not it were easier, wish you were better. Don't wish for less problems, wish for more skills. Don't wish for less challenges, wish for more wisdom. A great quote from Mr. Jim Rohn. So the antechamber is formed and the case is concluded. Thank you very much for your attention. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.